Welcome, everyone. On behalf of the American Heart Association, American Stroke Association, and our Healthcare Certification Division, I would like to welcome you to today's webinar panel discussion From Policy to Practice, Unlocking Stroke Recovery Access. The foundation of the webinar is the recent policy statement from the American Heart and Stroke Association, in which a majority of our speakers were key authors on. You have access to the published statement, and we'll go over some housekeeping items. And a special thanks to our advocacy division for making that publication possible. We also want to especially thank our collaborating organization, AMRPA, the American Medical Rehabilitation Providers Association, for joining us and making this webinar possible. My name is Steve Dennell from the American Heart Association, and I am the host for today's discussion. A couple of housekeeping items for today. All attendees are muted. Panelists will be the only ones on camera. There is closed captioning available and can be engaged by clicking on the CC icon at the bottom of your screen. And the session is being recorded and will be available afterwards. If you, we highly encourage that you ask questions and use the Q&A panel for questions at any time. If you experience any technical issues, try leaving and rejoining the webinar or checking your internet connection. We encourage you to stay until the end for the Q&A session from the audience members, and you can download the resources from the resource icon located at the bottom of your screen. And if you would like to connect with us, reach out to certification@heart.org. So, it's my pleasure to introduce our distinguished speakers today. Our first speaker is Neka Infajeka, who is the Chief Science Officer of Ochsner Health System, where she holds the Ferber Family of Yuma Endowed Research Chair and the Interim Associate Dean of Research at the newly formed Xavier Ochsner College of Medicine in New Orleans, Louisiana. She earned her medical degree at the University of North Carolina School of Medicine and her master's in public health and administration at the University of North Carolina School of Public Health, and completed residency in physical medicine and rehabilitation at Baylor College of Medicine, certified by the American Board of Physical Medicine and Rehabilitation in PM&R and brain injury medicine. Her research focuses on stroke recovery, care transitions, and health disparities, providing evidence-based rehabilitation paradigms through all levels of stroke care. Our second speaker, Dr. Lauren Shapiro, is board certified in both physical medicine and rehabilitation and brain injury medicine, and serves as the medical director of the Stroke Rehabilitation Program at Brooks Rehabilitation in Jacksonville, Florida. She received her medical degree from the State University of New York, Stony Brook School of Medicine, and then completed a residency in PM&R at the Northwestern University Feinberg School of Medicine program at the Rehabilitation Institute of Chicago, where she served as chief resident. She also earned a master's degree in public health from Johns Hopkins Bloomberg School of Public Health. Flannery O'Neill received her bachelor's degrees from American University and a degree in health from A.T. Still University. She's worked in healthcare and public health for more than 20 years in both the nonprofit and government organizations. Her areas of expertise include communications, data, public health program development, in management and organizational leadership. She currently serves as the assistant director of the Louisville Metro Air Pollution Control District in Louisville, Kentucky. Since experiencing an ischemic stroke in 2017, she has worked to advocate both personally and professionally for the needs of people experiencing stroke, including founding and leading two stroke support groups. In her downtime, she enjoys spending time with her husband and her dog. Um, Dr. Matt Reeves is a professor of epidemiology in the College of Human Medicine, Michigan State University, in East Lansing, Michigan. His methodological training includes a PhD in epidemiology from the University of Pennsylvania, and his public health training includes working at the Centers for Disease Control. His research interests have centered on studying quality of care and outcomes in stroke patients, including large clinical stroke registries such as the National Get With the Guidelines Stroke Program. Dr. Reeves also studies the use of patient reported outcome measures to document stroke recovery, including quality of life and well being. His interest in studying post stroke outcomes during the transition phase led to his interest in post stroke rehabilitation, where he has used large databases to study the comparative effectiveness of alternative rehab settings. Dr. Reeves also has served as chair of the Rehabilitation and Recovery Subcommittee for the Stroke Advisory Council. There is no disclosures from any of our speakers, and actually, for time's sake, there actually is more detailed bios that you can access as part of the platform. And disclaimer: the recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. Materials are for educational purposes only and do not constitute an endorsement or instruction by the American Heart Association, American Stroke Association. We do not endorse any product or device. And at this time, I would like to turn things over to Dr. Reeves.
Yeah, thank you, Steve. Appreciate that, and welcome everybody. And thank you for joining this webinar this afternoon or this morning, depending where you are. Yeah, I want to give you a quick overview of the content of the policy statement that you should all have access to. This again was published last summer and was an important, or is an important, really first policy statement about addressing the challenges of stroke rehabilitation care. So this overview of this policy statement, it includes text and sections on emphasizing the importance of stroke rehabilitation. It highlights some of the known inequities in access, particularly by comparing rural to urban and underinsured and minority populations. It also, as it says in the title, advocates for some very specific policy changes and directions related to improving rehabilitation equity and access, and also points out that a lot of disparities in care and access in the United States really focuses on the people who don't have insurance. And this is an example of potential disparities in access, even amongst those people with insurance. So we have problems of the uninsured for sure, but even people with insurance can have challenges, as we will discuss, in accessing rehabilitation care post-stroke. So why this matters? I mean, you're all on this webinar. I assume you're working in stroke. You have an awareness of the importance of stroke as a public health and a clinical issue, and of course, an awareness of the value of rehabilitation care. But let's just review that again. So we know that stroke is a major leading cause of disability and has wide-ranging effects on patients and their support networks, including caregivers and family members. We know from a lot of clinical epidemiological studies of the benefits of receiving post-acute care, rehabilitation specifically, in that it helps restore independence and improve functional outcomes. So it helps the stroke patients achieve their maximal function as early as possible. At least that would be the goal of early access to high quality rehabilitation care. As already mentioned, there are substantial known gaps in access to disparities to rehabilitation, particularly amongst rural populations and the underserved. And of course, we're very much interested in providing equitable care, making sure that everybody has access to the rehabilitation care that they need, that their function dictates what type of rehabilitation care they should receive. So, what are the key challenges in nationally in terms of delivering equitable rehabilitation care to stroke patients? As mentioned, we have these insurance and administrative barriers. I'm sure many of you on the webinar today will be well familiar with the challenges of prior authorization. They affect all components and all avenues of medicine, but they particularly problematic in the area of seeking approvals for stroke rehabilitation care and transfer to specific facilities. And you might well be familiar with the fact that there are high denial rates of stroke rehabilitation, which seem to be getting worse in recent times, not better. As mentioned, large geographic disparities. There are systematic differences in the rehabilitation resources across the country. Some areas are endowed with more inpatient rehabilitation beds than others. And so there's not an equal landscape in terms of the type of facilities that patients can access depending on where they live. As mentioned repeatedly, we've got strong evidence of socioeconomic and rural inequalities in access to care beyond these issues of just insurance and geographic disparities. And almost universally, what the report identified was has been a lack of focus on the importance of mental health services for stroke survivors, getting them to the health professionals. Recovery from stroke is not just a recovery from the physical ailments of stroke, but there's also huge mental health, or can be huge mental health and social determinants of health barriers to achieving that full recovery. So, what were some of the policy recommendations? I mean, there's a long list in this report, but just to point to three big ones. We want to see greater transparency in payer databases, meaning, we'd like to see their policies and the implementation of their policies in terms of who amongst the people they cover are getting rehab as requested. What are the delays in getting rehab as requested? We also want to see implementation of these 13 performance measures that have been developed following the release of the stroke rehabilitation guidelines, which occurred almost 10 years ago in 2016. So there are 13 performance measures, and we know from other areas of quality improvement, when you develop performance measures and implement them as a way of tracking and benchmarking care, that's how we can know whether we're improving care and access to care. Another area of emphasis policy-wise is support for caregivers, expanding mental health coverage both for the patients and the caregivers, and the potential to provide paid leave or tax credits for any family caregiving that they provide. And also would like to see greater expansion and removal of barriers to telerehabilitation. Some of these barriers to telehealth came down during COVID, but unfortunately have been reinstated since then. And so there's work to be done to really open up the full possibilities of modern day telehealth technology to improve access to rehabilitation specialists, particularly for rural isolated populations who don't have access to those professionals locally. Okay, so that was a rapid overview. And oh, sorry, one more. Evidence gaps and future directions. Yes, sorry about that. The report also includes a section on what we would like to see in the future. What are the research priorities? For example, cost effectiveness studies of different rehab strategies. One of the reasons we're in the problem in where we're at is because we don't have a good way of measuring the gain in function for a given rehabilitation setting relative to its costs and comparing that ratio, that cost effectiveness ratio, to other alternatives. That data would be essential if you really want to make evidence-based choices about the type of most effective and the most efficient rehabilitation care for a given patient. We want to see the collection of more patient-reported outcomes. We can only really gauge stroke recovery by asking the patient how they're doing. And so we want to see this data collected at, for example, 3 months, 6 months, and 1 year across a large representative sample of stroke survivors. We would like to see more research on innovative care models, particularly in this transition period, optimizing the transfer of hospital to home and addressing mental health recovery. And then there's also more work to be done on expanding and improving training and communication so that all healthcare providers who work with stroke patients are aware of the rehabilitation options, why certain rehabilitation options may be preferred for some patients over another, and are fully versed in the available evidence. Okay, now we can go to the panel discussion. So I'm going to lead this, or at least throw out some questions to the panel and get our feedback. We're going to do this for the next 25 minutes or so and finish up about a quarter to the hour, where, as already been mentioned, we'll go through some of the questions that have been posted during the webinar. So please, as you come across questions or critical issues you want to address, please post them in the chat, and those Steve will be curating those, and we'll be ready to answer those a quarter to the hour. Okay. All right, let's have a look at these questions that I have that I want to get some feedback from the panel. First is an easy warm-up question, if you will. I'd like to know from someone, why is stroke rehabilitation considered a critical component of a comprehensive stroke care? Who wants to take that?
Well, I'd love to jump in from a patient perspective. First, I and all of my fellow survivors are enormously grateful for the life-saving acute care that we receive, but that's really just the beginning of me. For myself and so many other survivors, we feel like we're living in a new body, and this is all a process to learn, how do I live in this new body? And rehabilitation in whatever form we need it is so critical to that. For me, aphasia was the primary disability that I was left with, and my speech therapist not only helped me rebuild my speech, but figured out, how do I reintegrate back into my life and into my workplace? And so it is just a critical component to comprehensive stroke care.
Great, thank you, Flannery. Lauren, maybe a question for you. What do we know about how early rehabilitation care influences long-term stroke outcomes? How important is this to get patients to maximize their full recovery?
Early rehab is really essential for improving long-term outcomes following stroke. Studies have shown that initiating rehab services early on results in improved functional independence, motor and cognitive function, and quality of life. And there's also evidence of reduced healthcare utilization when early rehab is provided. I like to think of early rehabilitation after stroke as a form of preventive medicine as well. One of the best examples of this pertains to the identification and treatment of swallow disorders after stroke, in which our speech therapy colleagues have immense expertise. This really enables us to implement preventive strategies to reduce the risk of aspiration, because when that occurs, it puts patients at risk for pneumonia and even death. Early rehab that's focused on mobilization can also help reduce the risk of other dangerous complications, including deep vein thrombosis and pressure injuries, as well as conditions that can impede function long term, like joint contractures. But it's critical to recognize that the timeliness of initiation of rehab is not the only key consideration. The intensity of services is also extremely important, and so is the training and experience and the care of stroke survivors of the rehab team members who are providing these services.
Yeah, thank you, Lauren. So, yeah, making the emphasis that it's we've got double challenges here in terms of figuring out the amount of rehab a patient will need and when to start it and the intensity. So, yeah, points all well taken. Um, Flannery, do you want to go back? Let's talk, expand a little bit more on your patient journey and uh, tell us a little bit more about how you see stroke rehabilitation helping you reduce your disability and improve your quality of life.
Well, I really appreciated that you highlighted the mental health and mental side of recovery, because recovery is not just a physical journey; it is a mental journey as well. Um, I my stroke was about 9 years ago, and in the beginning, there was no discussion of my mental health in my recovery. And so I had to seek that out on my own. And that's why in my bio, I talked about the support groups that I started. That was because in the community that I lived in at the time, there was no access to any sort of support system. So it really is important that we're looking both at the physical side of recovery, but also the mental side. And it may not be that survivors are experiencing diagnosable levels of depression, anxiety, other mental health disorders. But we are every day, our minds are just racing with, what is my recovery going to look like? Am I going to be able to participate in my family, participate in work, in the hobbies, earn income that I need to support my family? So comprehensive rehab cares for all of those aspects, and not just the physical side of things.
Yeah, thank you, Flannery. It's great to hear, your individual perspectives having gone through this. And I know we all know, talking to stroke patients during their recovery phase that, these mental health or stress, mental stresses on the recovery process are really often the most common manifestations of stroke during this recovery period. So appreciate that. Let's pivot now. I talked in the intro there about the problems of inequities in stroke rehabilitation care. So, Naneka, do you want to review for us some of the significant barriers that you see? We know in the literature about accessing stroke rehabilitation services.
Sure. So some of the largest inequities I see are related to insurance status, whether you have insurance or you do not have insurance. Some inpatient rehab facilities, skilled nursing facilities, post-acute care facilities actually do take uninsured patients, but there is no real breadth or depth of which ones do. And so if you're going into a hospital with acute stroke, there's a responsibility of that stroke center to care for you. Rehabilitation is viewed as elective, but we all know that it's quite essential. Other disparities come in when it comes to type of insurance, and we're going to get into details around that. Commercial insurance versus Medicare or Medicaid. Then within the Medicare Advantage versus traditional Medicare. Those are some dichotomous variables that we have to deal with when it comes to insurance. Finally, there is geography. So there are a little over 1,100 inpatient rehab facilities in this country, compared to over 10,000 skilled nursing facilities. And those inpatient rehab facilities are usually located in urban metropolitan areas. So if you need inpatient rehab facility care, which is the highest intensity care that portends the best outcomes post-stroke, if you don't live geographically close to an inpatient rehab facility, you will not have access to that important level of care, which helps portend better outcomes. Finally, there are disparities when it comes to whether you have a rehab provider on the acute care side. So, a part of my role before I became an administrator is I am a stroke physiatrist, and I was a stroke physiatrist on an inpatient stroke unit. So, everyone saw me. I was a part of the order set. So in the ER, you didn't even have to check me. I was automatically checked. So I saw every patient on day zero. That makes a huge difference when it comes to access to care for a stroke survivor. If you have a rehab physician seeing you on day zero, I can change the path of where you go versus having someone who does not have access to an inpatient rehab physician who can help them get to the most intensive level of rehab care. So in some institutions, in some organizations, they have no idea of until it's basically day 3, 4, or 5. And then all of a sudden it's like, where's the patient going to go? Where's a rush to discharge the patient? And they really haven't put the steps in place to get them to the optimal level of post-acute care. So again, it's important at each of our facilities that you have someone who literally has hands on the patient early during the acute stroke hospitalization to determine whether they are a candidate for intensive rehabilitation, if they have a location in their area, whether they have caregivers who can provide the care during inpatient rehab stay and beyond, and whether there's the appropriate access to care that you need after inpatient rehab, either in outpatient or home health settings, to get the best outcomes. And all of that's facilitated by having a strong rehab provider during the acute care hospitalization.
Right, thanks, Nineka. That was an excellent summary of some of the challenges with these inequities. So obviously, some of these aren't fixable readily with in terms of particularly with geographic differences. Um, can you tell us a little bit more about maybe disparities in specific populations? I'm thinking underserved populations, and whether there's any strategies we might think about for how to reduce those.
Absolutely. So within the underserved population, I can start with the Medicaid population. So each state has different Medicaid programs, and some states participated in the Medicaid expansion, which included inpatient rehab facility and post-acute care stays. I live in Louisiana right now. Participating in the Medicaid expansion, patients who have an acute stroke can go to inpatient rehab and have it covered. I came from the state next door, which did not participate in the Medicaid expansion at all, which means that those patients who have a stroke will have acute stroke care, but post-acute care, they may not have any access to inpatient rehab facility care, let alone outpatient therapies or home health therapies. So Medicaid and your state's ability to participate in Medicaid expansion, huge impact on care. As again, rural. If you live in a rural hospital, again, you can get telemedicine, you can get drip and ship, and you're brought to the mothership for your acute stroke care. But when it's time to get post-acute rehabilitation, most people want to be close to home because, financial concerns. They want to be close to their loved ones. I've actually had patients who wanted to be close to their pets again. You'd be surprised about how attached people are to their dogs and cats. And they can't bring those to the mothership hospital. They want to be close to home. And so having rural access to post-acute care is a concern. And that's where telerehabilitation could potentially come in, and we'll talk about that a little bit later. Then we have racial and ethnic disparities, which I've published on this topic. There in some institutions, in some organizations, based on your race or ethnicity, you have decreased access to care. There was a paper that we published looking at the BASIC data. BASIC is Brain and Health Surveillance in Corpus Christi, headed up by Lewis Morgenstern at the University of Michigan. And we looked at patients who had the exact same insurance, Hispanic and non-Hispanic. The Hispanic populations had less access to inpatient rehab facility care with the exact same insurance, exact same stroke severity, everything equal apples to apples, no apples to oranges at all. So that is something that is an unconscious or possibly conscious bias that we're dealing with in this country as well. And it's not related to choices, or it's not related to the family, it's not related to the patient's preference. No. We're just talking about rehab recommendations for post-acute care at an intensive level, and the patient just simply doesn't get it. And I've published on this topic as well. So these are other things that we're having to deal with, these biases when it comes to access to care that are related to racial and ethnic concerns. There's also a language barrier. So if English was not your first language, I published on this in 2021. If you speak a non-English, non-Spanish language, and someone has to use a translation service line for you, you're less likely to have inpatient during acute stroke, occupational therapy, and physical therapy. Well, how do you think we decide on who goes to inpatient rehab? It's the intensity of therapies, whether you could tolerate 3 hours of PT and OT or PT and speech a day. Well, if nobody's coming to your room to evaluate you for physical therapy, how can you get post-acute care? So again, language barriers, non-English, non-Spanish. You also have decreased access to post-acute care because you're not getting the acute care rehabilitation that you need.
Good. Thank you for that summary, Nanika. We've heard a lot about insurance and insurance barriers, and I think, Lauren, you wanted to share some slides with the group looking at this issue in some more detail.
Yes, thank you so much. We face a lot of insurance obstacles, and they significantly impact access to rehabilitation services. We see very long delays in authorization for services, particularly to post-acute care settings. We often see patients are sent to less intensive post-acute settings, even when inpatient rehab facility or the IRF level of care is not only available, but medically necessary, and really what is very much needed for the best optimal outcomes. We see a lot of premature denials of continuations of stays once people are at such facilities. And we see patients reaching so-called caps or thresholds that don't really consider the patient's level of impairment nor their necessity for ongoing services. Certainly, these obstacles are not unique to Medicare Advantage or MA plans, but I think they warrant some additional discussion today because they have become increasingly prevalent in terms of more and more Medicare beneficiaries are enrolling in these plans, and because their practices are particularly challenging. And they were subject to a Senate report from 2024, where it was found that many of these MA plans were not providing the benefits that were easily accessed by traditional Medicare beneficiaries. And although it's not stroke-specific data, we find that those with MA plans are discharged to inpatient rehab at rates of about a third of those who have traditional Medicare. MA beneficiaries are less likely to discharge to post-acute care more generally. And if they do, they often experience significant delays in authorization and as a result have longer acute care lengths of stay. Now, those of us who work in inpatient rehab facilities like myself understand very much the pressures that those in acute care are facing with regards to keeping lengths of stay relatively short, as so long as it's safe, of course. But there are also problems for the patient when you unnecessarily prolong a hospital stay, including complications of immobility like pressure injuries, contractures, and deconditioning that make subsequent rehabilitation more challenging. We often see an over-reliance on psychotropic medication and often suboptimal bladder and bowel care. Next, please. MA beneficiaries also have slightly shorter lengths of stay in IRFs after stroke, although that mean is not all that impressive and 0.11 days shorter. However, in the field, I can tell you, we often see these cases where there's this very abrupt decision to deny continued length of stay. And this is really problematic because sometimes we need a little bit more time for caregiver training. Maybe the patient still needs some help transferring and the family member has been present and they still need a little bit more practice, or the patient needs a little bit more practice before they can safely discharge to a community setting. And often we're waiting for something like a ramp to be installed in the home or a piece of equipment. And what's a growing problem is we're often given these really, really short windows, typically 2 hours, to call for a peer-to-peer to allow continued length of stay. And as a busy clinician, it's really hard to get these done within 2 hours. Sometimes I'm in clinic and I'm doing botulinum toxin injections to manage a patient's spasticity, or another patient on my inpatient rehab service is having a medical emergency and I need to be at their bedside. Or I'm in a team conference meeting with all the therapists and nurses so that we can further plan our patient's care. So these 2 hour windows are really, really a challenge, particularly on the inpatient rehab units. And although we really strive to get our patients discharged to community settings, in reality, some of our patients do need to discharge to subacute rehabilitation. Often something has changed in their social situation, or they just need more time for recovery, or perhaps ongoing close nursing management for a wound or perhaps IV antibiotics. And it's extraordinarily difficult to get authorization for the subacute level of care if they're not able to go home. I was asked to comment a little bit about necessary payer policy reforms, and these are my own kind of informed opinions, I guess. I think it's important that there be some sort of mandated limited turnaround time for MA plan determinations for initial authorization for IRF. I think 24 hours would be quite reasonable. AMRPA has some data from its members, a survey that was completed in 2024, where the average time for the initial decision for authorization for inpatient rehab was 2.5 days, and that is just simply too long. We need to push for transparency from the Medicare Advantage and other private payer plans as to how they're determining post-acute care necessity. They are often hiding behind algorithms that we don't fully understand. And it's important that there be standardized criteria and ideally that they be consistent with Medicare guidelines. And lastly, I think it's really important to establish a minimum amount of time of advance notice when a peer-to-peer call is required. Those of us who work in rehabilitation want to be strong advocates for our patients, but it's very hard to do this and meet the demands on us to care for other patients and manage the rehabilitation team.
Yeah, thank you, Lauren. That was excellent summary and obviously describing quite a disquieting environment for uh, physiatrists like yourself trying to provide the best care. I would ask the people listening to this webinar if you've got similar experiences, just document those in the chat, if you will, because it would be interesting to see whether these experiences, which we believe are widespread, are actually being experienced by members on the call today. So I encourage you to do that. Okay, let's thanks, Lauren. Let's pivot to some other questions. And again, we've focused a lot about the equity challenges of providing care. So I want to get the input of Flannery and Aneka about why is equitable access to stroke rehabilitation absolutely critical for long-term recovery? Why do we need to fix that?
Flannery, I can head it off if you don't mind. So I went into physiatry because I understand the importance of recovery. My uncle, my granduncle, who I spent every summer with in Charleston, South Carolina, I'm from Washington, D.C., so a city girl going to Charleston is a big deal, had a left MCA stroke. And I was in medical school at the time at UNC. And I would have to drive to Charleston to make sure that he got stroke rehabilitation care. He had aphasia, people didn't understand what he was saying, he wasn't getting the care that he needed. And so I made sure that happened. And it actually changed me from applying to neurology, sorry, Mitch, if you're here, to physiatry because of what I went through driving from Chapel Hill to Charleston to care for him. And I think that that's pretty important, the need for stroke rehabilitation. So he was alive, but he wasn't living. And that's what rehabilitation gives to stroke survivors, their families, their communities, the ability to live. And it may look different than it was before, but it's still a life. And I think that we don't stress that as much as a stroke community as we should. We get them through the acute stroke hospitalization, but the average length of stay now is about 5 days, y'all. What's going to happen for the rest of everyone's life, the survivor's life, the community's life, and what are we doing to contribute to that being a positive experience? And so I think that we have worlds of work to do when it comes to making sure that stroke rehabilitation is elevated to the level of acute stroke care. And this policy statement is a start of that. This is a very strong statement. And I'm so thankful that the AHA is doing this to say, look, it's time. Not just for us. We understand we need to change what we're doing when it comes to the data that we're collecting, the outcomes that we're measuring, but it's also on the hospital systems, the policy system, the insurance systems, our healthcare systems. This all has to change because the age of a stroke survivor is getting younger. We have a lot of young stroke survivors who are mothers, who are still working, who had 20 or 30 more years estimated in the workforce. and they are unable to go back to work because we haven't thought about rehabilitation paradigms that fit their needs. So, stroke rehabilitation should be elevated to the level of acute stroke care. This policy statement is our first important step making that happen.
Yeah, thank you, Naneka. Pivoting on that point, let's talk about the specific policy changes you want to see, and particularly the advocacy for those policy changes. So, who do we think can help move the needle on improving access to care, covering these gaps, fixing some of the almost egregious approaches for some of the companies involved with uh, covering stroke survivors. So, who might be the stakeholders that we can look to help us do this?
So the first step I would say is, actually healthcare systems, patient advocacy groups, us as stroke rehabilitation providers, people who are not stroke rehab providers, but actually have hands-on stroke patients every day. So we're talking about vascular neurologists, cardiologists, ER doctors, talking about all of our therapy staff, PT, OT, speech, vocational rehabilitation, really important that we don't really talk about a lot. Those are the people who help you get back to work, as well as policymakers. So that means going to Capitol Hill and lobbying. It's important to realize that it only took one congressperson's wife having kidney failure for all of a sudden end-stage renal disease is covered immediately by Medicare. And I mean immediately in the hospital. But for my stroke survivor to get on Medicare, it takes 2 years. And it's 2 years of lobbying and hiring a lawyer and going back and forth. And sometimes during that 2 years, you don't have the ability to keep up the fight. And you end up being uninsured and you end up getting readmitted because you didn't take your medication because you don't have the money to do so. You didn't get rehabilitation, so you have this level of debility. You fall and break a hip. So I think it's going to require all those levels of people who are advocating, and it's going to be an uphill battle, but it's something that we must do. And remember, y'all, there's some people in Congress who are having strokes right now. And I think it's really important to kind of get their ears as well, because Congress is a different level of, insurance. They don't have Medicare there, y'all. They have their own special golden parachutes of insurance. So it doesn't really affect them. But stroke affects all of us. Stroke affects everyone. And we need to make sure that we have the appropriate channels in place to effect change.
Yeah, good. Thanks, Naneka. Flannery, do you have any comments on this area as a patient, as a survivor, and you've obviously done some advocacy work?
I think patients and their families, their caregivers are also a really important advocacy or group that can advocate because we're living and breathing this every day. We've touched a little bit on underserved communities, but I experienced my stroke in a rural community. Got to experience the drip and ship myself, and came back to a community where I was fortunate I had an option, but I had one specialist in each category to choose from. So again, I was fortunate because of that, but also I had no choice. I had that one specialist to go to, and it was not higher level of specialty. It was kind of the general cardiology and general speech therapy. And so there we have a lot of experience and a lot of needs. And so bringing patients together and hearing our voices about what we need is also a really important part of seeing the change that we're calling for in this paper.
Yeah, thanks, Tony. I think, yeah, a voice of patients, voices of stakeholders, voices of physicians on the front line, all of these are important stakeholders who can help move the needle on these necessary policy changes. We're almost a quarter to the hour. We have one more question we wanted to cover, and maybe Lauren can start with this, and that was, the policy paper talked about the potential and future of technology and telerehabilitation for stroke recovery. So, Lauren, do you want to speak to that? Maybe address how such technologies could maybe improve access, particularly to isolated communities?
Sure. Telerehab can play a really important role in improving access. And I would say not just in rural areas, but a lot of our patients have pretty significant transportation challenges. And some patients have severe immunocompromise. I know there's a lot of flu in the community right now, and some may benefit from more advanced home telerehabilitation during this time. It can also provide access to PM&R physicians in places where there aren't any currently. And there's emerging evidence it can improve motor function and balance and can be really, really effective for aphasia rehabilitation. I know it's really hard sometimes to get home speech therapy through traditional home care companies, but aphasia therapy can be done very well remotely. Obviously, though, it can't take the place of hands-on therapy for some patients, particularly those that require very substantial levels of assistance with mobility or basic ADLs, or who may benefit from manual therapies or the use of really specialized equipment. It's hard to, for example, put like a body harness in someone's home, but it still can be a very important adjunct form of treatment in their rehabilitation, even in those cases.
Yeah, good. Thanks, Lauren. Any other comments in the panel on that issue? Okay, good. Well, we're right at quarter to hour, which is where I wanted to be, so we've got enough time now to address some of the questions. So, Steve, I think you've been looking at the questions that have come in. I assume there's some been coming in. So,
Yeah, thank you, Dr. Reeves,
take it away.
and thank you especially to the audience for submitting so many questions. We will try to get to as many as possible, and the ones we do not get to, we actually will work with the panel to send out responses to you all. So, one of the great questions that came in is what strategies does this panel recommend to optimize success in achieving insurance approval to admit stroke survivors who need inpatient rehab, especially with managed Medicare population?
Um, I could certainly answer that. I think it's very helpful to have PM&R consultants in acute care who can help make and document that case. I know there are not enough of us to go around and cover every acute care hospital, but if there is one available in your community, I would definitely make use of their services. I would also encourage patients, and often they must depend early on their families, to make their own appeals when they're hitting denials or delays. I know it's really challenging sometimes, and there's a lot on their plate. I often coach families through this process. Chat GPT and some of the other AI technologies can give you a little bit of a template if you type in information. And I very much encourage them to request these appeals. There's often an expedited appeal process, and many inpatient rehab facilities have shared their data on how successful these family appeals can be.
So that's excellent, Lauren. And I will add something to that. During the pandemic, well, prior to the pandemic, there was a requirement on inpatient rehab facilities that you do a pre-admission screen, a post-acute physician assessment, and individualized overall plan of care. And the whole point of that is to deny stays. And so we went to Congress, and Congress said, "Oh, you think this is too much documentation? Prove it." So I pulled some Get with the Guideline stroke data, and I published two papers. And I went back to Congress, to CMS in Baltimore, and I had the two papers and said, "You see this? Ever since y'all passed this law in 2010 requiring these three levels of documentation, inpatient rehab referrals have gone down this much." And they held on to those papers, and then COVID hit. And wouldn't you know it, one of those types of documentation disappeared and it stayed away forever. The post-acute physician assessment no longer exists. It's a pre-admission screen and an IOPOC. All this to say, you need to have some manuscripts. You need to have some publications in your pocket. So I would pull 3 or 4 publications showing the importance of inpatient rehab facility care for stroke survivors and the outcomes related to it. Make sure the members of your acute stroke team, if you don't have a physiatrist there, have those publications in case they get called and cite those publications. It's very difficult to go against published data because they have a whole playbook of how to deny you. You need to have a playbook of how to get past that denial.
Yeah, good.
Dr. Reeves, there's a speaking with the guidelines, or the first question that actually came in. For those sites participating in Get with the Guidelines Stroke, can data be pulled from that platform regarding 30-day and 90-day modified Rankin scale scores in discharge destination of inpatient rehab facilities?
Yeah, it's a great question. Unfortunately, the answer is no. We don't systematically collect data on recovery, MRS, modified Rankin, as the participant mentioned. So there was an attempt to collect data at 30 days with a post discharge tracking form in Get with the Guidelines, but it's not used consistently enough. And so this is the one of the big challenges, is that we have no systematic way of understanding stroke recovery once patients leave the hospital. And that's obviously a huge gap in our knowledge, and makes it challenging to line up to prove, the benefit, really show, like Neka was just talking about, you need the data, you need the publications. We would like to have that data so we can show, look, when patients get this type of rehab, this is their outcomes 90 days and 180 days later. We have that data in specific studies, but we don't have that systematically across the whole system.
So I did the paper, I pulled a paper, I put it in the chat. I think I answered someone's question. In my lab, we did it for about 800 patients who were discharged from UT Southwestern's post inpatient rehab facility, and we followed them to 90-day MRS. This was not easy and it was not fun, but we did it. And we created a GG score. Does everybody know what a GG score is? It's the scores that PT and OT calculate when you're on inpatient rehab facilities or SNFs. We created a GG score to MRS crosswalk, so all the stroke rehab people could talk to all the acute care people. And we found that if you go to inpatient rehab versus going straight home after a stroke, your 90-day MRS is actually better if you went to inpatient rehab, even though you have a more severe stroke. And we published that in JSCVD about 2, 3 years ago. I think that was first authored by Dr. Manchi, and I put it in the chat. I answered someone's question to it. It is from the Melinda Carter's question, that PubMed reference. That's in JSCVD. But again, we use some Get with the Guidelines stroke data, but then we also created our own data set, followed the patients for 90 days, and then calculated MRS and GG codes crosswalk. So we're creating the data, but in Get with the Guidelines stroke, it does not exist. I believe they're trying to collect 90-day MRS now, Matt, but there isn't a lot of data points on it. In addition, there's no data for post inpatient rehab facility discharge. Whether you go home or whether you go to hospice or whether you go to SNF, that does not exist.
Yeah, exactly. Yeah.
I'm gonna put Flannery on the spot now. So there was a great question about a second. Let me pull it up. Someone wanted to start a stroke support group, and I'm not sure where the question went. It was here.
I might have beat you to it. I was typing an answer in the question box. That is a fantastic question. So there's some wonderful resources on the American Heart Association website of how to start a support group. It really, to answer the question of is virtual versus in person better, it really depends on the audience you're trying to serve. When I lived in my small town, in person was really perfect for us because we were trying to build some community physically in that community. But now I run a virtual group for young survivors, and we've got survivors all across the country. And so it just, it can work both ways. I certainly do miss the in-person aspect to my group, as I've only met some of my participants, once or twice. So just depending on the goals of your group. And American Stroke Association has a lot of great content for topics. That can be really challenging to come up with new and interesting topics. They have several different topic areas and presentations, so you can pull that content and use that in your group.
Thanks, Flannery. This is a tele-rehab was brought up as part of the discussion. There's a question: are there current guidelines or suggested protocols for structuring a tele-rehab program in community hospitals?
I don't know of any.
I don't know of any either.
Dr. Shapiro?
I don't know of any. When you're talking about hospitalized patients, I think it's really challenging. There's some elements of that rehabilitation that could probably be done remotely. Again, aphasia evaluations, I think, is pretty reasonable. But when you're first mobilizing a patient out of bed following a stroke, I really do think you need in-person therapy personnel. Tele-rehab could be helpful in providing early education, perhaps, but I don't foresee that taking the place in acute care, at least, of in-person therapy.
Thank you. There was it was brought up about performance measures for rehab. Um, Jessica asked the question. I am curious about how you envision how to optimize the performance measures for rehab.
Yeah, I saw that question. I thought it was a great one because I didn't know the answer immediately. So,
Yeah.
I mean, I think what has to happen, and I don't know where we're at in these processes that, typically the process is you develop guidelines that says like these are minimum standards of care, and from that you typically take like the class one recommendations and create performance measures. And then that, which takes the time to get these endorsed. But from that point on, what you really need to do is develop a work group or committee that then starts working on the implementation of these performance measures, in the clinical venues where this data is to be collected, and then also developing incentives and benchmarks. And so really incorporating the performance measures into a formal quality improvement and implementation process. I've seen that work, for example, inpatient stroke measures back in the day when we first developed those, back in 2008 to 2010. We got the CDC Joint Commission agreed upon 10 performance measures. So I don't know. This is long-winded answer. So I don't know where we are in that process about who's taking charge of those performance measures and how they're being implemented. But obviously, if they're going to have an impact, we need to find the answer to that. So, Steve, maybe that's something we can follow up with AHA on and figure out where that's at and what's the group that's working on that.
Absolutely. Um, let's see. I'm trying to. Well, we are. There's less than 1 minute left in the call. Any final comments from the group?
Well, on behalf of the group and on behalf of everyone who participated in the policy statement writing, thank you all so much for attending this webinar today. We had over 350 attendees at one point, and I'm looking forward to hearing additional response from people who watch this recorded. And again, fight the good fight. You are not alone. It may seem that way sometimes in your center, but I assure you, you are not. And I think that it's really important that we continue to be insistent and persistent when it comes to stroke rehabilitation for all. So thank y'all so much for attending.
Yeah, and I just wanted to first off, most importantly, thank the panelists for their time and their efforts specifically on this important paper and advocacy work, and really the work that is being done. I really wanted to additionally thank all the audience members and the questions that they submitted, because it really made this wonderful presentation, and most importantly, our collaborating organization. I can't thank the American Medical Rehabilitation Providers Association enough for not only recommending Dr. Shapira to be on this group and her expertise, but the great work that they continue to do in the advocacy work that hopefully we can collaborate on in the future. So, again, on behalf of the American Heart Association, we just want to thank you for your participation and have a great day.
Thank you, everyone.
Bye, everyone.